Good evening. My name is Nicholas Hanle, and tonight I'm going to be talking to you about glomerular filtration rate. The objectives today are first to describe the composition of the glomerular membrane. Next, we're going to move on to explain the forces behind glomerular filtration. Then we'll move on to define the glomerular filtration rate. And finally, we'll be able to discuss how glomerular filtration rate is controlled in the body. So if we start by talking about the glomerular membrane, it has three basic layers to it. Okay, glomerular capillary wall is this layer up here, represented with the number 1. Then it has a basement membrane, and then finally we have the inner layer of the Bowman's capsule. The glomerular capillary wall is a single layer of flattened, squished endothelial cells. Um, it does have a bunch of large pores in it, as you can see between these two red cells. So making it through there, we do have those pores. Not only do they have traditional pores found between the cells, they also have endothelial cells themselves are also perforated by large holes or fenestrations that you can see in the picture here. The next membrane, the basement membrane, is an acellular or a gelatinous layer, meaning there's no actual cells there. It's largely composed of collagen and glycoproteins, and those are sandwiched between the glomerulus and the Bowman's capsule. So the collagen's there for structural support or strength, and the glycoproteins help discourage filtration of small plasma proteins. The large proteins can't make it through just because of the size of the openings, but the smaller ones need a little bit of incentive there. So due to negative charges on a lot of them, it prevents them from passing through. Finally, we have the inner membrane of the Bowman's capsule. We can see here, lining there. This is the final layer, and it has podocytes into it, which are like octopus-like epithelial cells. So they have branches that stick out. They have like primary feet that stick out, and then those primary feet have secondary feet branching off of those, and they can intertwine with each other and forming kind of like a zipper type thing, or it looks like a fern plant. But filtration slits are actually formed here between the interdigitating secondary foot processes of adjacent podocytes, and that provides a pathway through which liquid or fluid from the glomerular capillaries can enter the lumen of Bowman's capsule. So lots going on there. Overall, the purpose of these membranes is to act as a molecular sieve where they catch some things and they let others pass. That's where we get our selectively permeable membrane here. Basically, it's going to retain the blood cells and the plasma proteins, but allows the water and other solutes of small molecular dimension to pass through it. And then finally, there are capillary beds throughout the body. The glomerular membrane has a much greater permeability than other capillaries in the body, just because of what's going on here in the filtration process we're going through. Okay, so now let's talk about the forces that exist behind this glomerular filtration. Overall, the major force that causes the glomerular filtration is the glomerular capillary blood pressure. So basically, force is needed to push or drive the plasma in the glomerulus through the openings in the membrane. We don't use local energy. It is a passive process to move things across here. So it's similar forces to all the other capillary beds throughout the body, but basically there's a couple differences that occur here. First difference is that glomerular capillaries are more permeable than capillaries elsewhere. Because they're more permeable, they're able to filter more fluid at a particular filtration pressure. Okay, and the second difference is that the forces across the glomerular membrane are so balanced, or the way they work out is throughout the entire length of the tube, that the entire length is able to perform filtration, whereas in other areas or other vessels, the beginning part of the vessel is where filtration occurs, and by the end of the vessel is where you see reabsorption. So again, lots of good stuff there. Let's look at the actual forces that go through here. So there's three main forces that affect glomerular filtration. Those three forces are glomerulus capillary blood pressure. I'm going to abbreviate that GCBP just because it's a mouthful. And then we have plasma colloid osmotic pressure. And the third one is Bowman's capsule hydrostatic pressure. The first, glomerulus capillary blood pressure, this is the one of the three forces, or the only of the three forces that favors filtration, as you can see here. So what happens here is the fluid or hydrostatic pressure exerted by the blood within the glomerular capillaries is what this blood pressure is. It depends on, obviously, the contraction of the heart, so cardiac output, and resistance blood flow offered by the afferent and efferent arterioles. The average value here is around 55 millimeters of mercury, which is higher than blood pressure in other capillaries, but it's higher because of the large diameter of the afferent arterioles compared to the efferent ones. Basically, the afferent allow more blood to travel into the glomerular space, and then the efferent is a little smaller, so we kind of get a damming effect that occurs here. So the pressure builds up a little bit more than it would elsewhere. And again, this is also why we look at this, because of this pressure. This is why we have non-decremental glomerular blood pressure, and it's going to push the fluid out of the glomerulus into Bowman's capsule over the entire length of the capillary, and that's a major force producing that glomerular filtration. Okay, the second force here is the plasma colloid osmotic pressure. This is caused by an unequal distribution of plasma proteins across the glomerular membrane. Those plasma proteins aren't typically filtered, so they're in the glomerular capillaries, but they're not in the Bowman's capsule. So in this case, what happens, the concentration of water is going to be higher in Bowman's capsule than it is in the glomerular capillaries, and water likes to move through osmotic pressure gradient from high water concentration to low. So in this case, the water wants to go from the Bowman's capsule back into the glomerulus, which is the opposite of what we want to happen. So the plasma colloid osmotic pressure actually acts against filtration. So in this case, it averages about 30 millimeters of mercury, again, slightly higher than it is elsewhere. And then the third force here is Bowman's capsule's hydrostatic pressure. And this is the pressure that gets exerted by the fluid that's inside the Bowman's capsule on the initial parts of this tubule. This pressure, again, is acting against filtration because it tends to push fluid out of the Bowman's capsule. So moving in that opposite direction for us, but the average here is about 15 millimeters of mercury. So those are the main forces that are acting. All three forces work. The glomerulus capillary blood pressure is in favor of filtration, and the other two oppose filtration. So these three forces, if we combine them, they are imbalanced. There's more pressure going into it, causing the filtration by the glomerulus capillary blood pressure. So when we add those terms up, the 55 plus or minus the 45 total there, we get a net filtration pressure of 10 millimeters of mercury. Now the numbers in this picture are a little off because I grabbed them out of another book, but the 60, 32, and 18 don't match up to what our book said, but the overall net filtration pressure does work out to be 10 millimeters of mercury pushing out, so filtration would occur. So this forces large volumes of fluid from the blood through the highly permeable glomerular membrane. And when we're looking at glomerular filtration rate, or GFR, it depends on the net filtration pressure. So we just got that one from the last part, but it also depends on the filtration coefficient, or KF value. That filtration coefficient depends on two things: the surface area of the glomerulus and the permeability of that glomerular membrane. So we multiply those two things, that gives us our glomerular filtration rate. So normally it's about 20% of the plasma that enters the glomerulus is filtered out of the net filtration pressure of 10 millimeters of mercury. This produces around 180 liters of glomerular filtrate per day for an average GFR of 125 milliliters per minute in males. That goes a little bit higher. It's 100 or a little bit lower in females, 160 liters per day and 15 milliliters per minute in females. So now if we look, most changes in GFR are going to come from glomerular capillary blood pressure. Because that filtration pressure accomplishes, filtration is simply the result of an imbalance of those opposing forces. Those three forces are what we're going to use to determine how much our GFR is. Now, unregulated influences on GFR, the plasma colloid osmotic pressure and Bowman's capsule hydrostatic pressure normally don't vary a whole lot, so we really don't regulate them, or we can't regulate them actively. Now, there are some pathological things, like due to injury or illness, that can cause those things to change. And that could inadvertently affect our GFR. For example, if we look at a patient that has severe burns, the plasma protein concentration might drop severely due to the burned patients. They lose the large quantity of that protein-rich plasma-derived fluid through the exposed burn surface skin. So by losing that kind of pushes or forces causes a decrease in our plasma protein concentration. That's going to reduce our plasma colloid osmotic pressure. Now, in the opposite there, if we had somebody with dehydrating diarrhea, in that case, the osmotic or plasma colloid osmotic pressure would actually rise, and that would cause our GFR to fall. So the plasma colloid osmotic pressure and GFR kind of have an inverse relationship when pathologically something's going on. Now, Bowman's capsules, hydrostatic pressure can become uncontrollably elevated, and so filtration can decrease in urinary tract infections. So if you have some sort of obstruction, like we're shown in the picture here, the kidney stone, if we can't remove fluid from the Bowman's capsule to excrete, then we're going to have a buildup behind that, and that pressure can reduce the GFR because we can't push anything beyond that point. Now, controlled adjustments in GFR is kind of a little different thing. And again, we're going to go back to the glomerular capillary blood pressure here, and we can control that to adjust GFR to suit the body's needs. If all other factors are constant, as the GCBP rises, so will the filtration pressure go up, and thus GFR is going to increase. The magnitude of this change depends on the rate of the blood flow within each glomeruli. So this is mainly controlled by the mean systemic arterial blood pressure, and then resistance offered by those the afferent arterioles. So if afferent arterioles resistance increases, less blood flows into the glomerulus, that decreases GFR. If afferent arterioles resistance decreases, they widen, then more blood's going to flow in, and that's going to increase GFR. The two major mechanisms we use to control this, or to regulate GFR, and are going to be through autoregulation, which is a short-term thing, or extrinsic sympathetic control, which is more of a long-term regulation of that arterial blood pressure. So we have a short-term and a long-term to make this work. Okay, autoregulation of GFR is dangerous if the GFR is constantly changing due to blood pressure. So if our arterial blood pressure is the main factor controlling our GFR, as we exercise and do other things in everyday life, we're going to be messing with that. So we don't want that to happen immediately. So we prevent this through autoregulation, and we do this with two mechanisms. So there's the myogenic mechanism and the tubuloglomerular feedback mechanism. In the myogenic mechanism, this is going to respond to changes in pressure within the nephron's vascular component, whereas the TGF is senses changes in the salt levels and the fluid flowing through the nephron's tubular component. So the myogenic mechanism, basically arterial vascular smooth muscle is going to contract in response to stretching of the vascular smooth, or the stretching of the accompanying increased pressure within the vessel. So as the arterioles are stretched, they're going to kind of constrict on its own, and then increased arterial driving pressure is going to be there. By doing this, we help limit the blood flow into glomerulus to normal. So if our blood pressure is up systemically, our afferent arteriole will kind of constrict so that it limits how much blood flow can get in. So we can kind of maintain our GFR within a normal range. If our blood pressure is too low, then we can open that afferent arteriole and we can allow more blood to come in, and that'll keep the GFR up. So kind of work in two ways there. Now with the TGF, it involves the juxtaglomerular apparatus, which is a combination of tubular and vascular cells where the tubule, after leaving, bend back upon itself and passes through the angle. So we form a kind of efferent arterioles, kind of a loop where we have all that joined together. Within there, we have some granular cells because they contain many secretory granules, and there's a region known as the macula densa, and these cells detect changes in the salt level of the fluid that's flowing past them through the tubules. So if we increase more fluid passing through there, the normal filtered and then flows through the distal tubule. As we're watching that stuff, the macula densa cells can release ATP and adenosine, both of which act locally as a paracrine on the afferent arterioles, causing it to constrict, thus reducing glomerular flow rate and returning GFR to normal. In the opposite situation, when less salt is delivered to the distant tubules, due to a fall in arterial pressure, less ATP and adenosine gets released by these macula densa cells, and then afferent arterial vasodilation increases glomerular flow rate, restoring GFP to normal, or GFR to normal. We can also excrete nitric oxide from the macula densa cells, and that's going to actually stop the action of ATP and adenosine completely at the afferent arteriole. So by the means of this mechanism, the tubule of the nephron is able to monitor the salt level of the fluid flowing through it and adjust the rate of filtration of the nephron accordingly to keep the early distal tubular fluid and salt delivery constant. So we want to maintain a certain salt level, and we want to keep it where it is, so we need to go through those processes. Okay, the importance of autoregulation of GFR. Both of these mechanisms used work to autoregulate GFR within the mean arterial blood pressure range of 80 to 100 millimeters of mercury. Okay, so that's normal range. Normally we're around 93 millimeters of mercury, so that range even includes when we're exercising. The main way we do this is by adjusting the radius of arterioles. Again, we shift the GFR. By shifting that, it could lead to imbalances. So if we're unregulated, we could lead to increase or decrease urination. So if we're exercising, we need to retain some of that fluid and everything because we're sweating and everything else. Our blood pressure is going to increase. If we would follow the typical trend and filter more blood and do all that stuff, we would lose more fluid in urine than necessary. At the same time, if my blood pressure drops, I don't want to slow down the process because again, that could decrease urination when I need to be getting rid of those wastes. So we want to maintain that process. But once we get outside of the range of 80 to 180 millimeters of mercury, then autoregulation really can't do a whole lot for us here. Okay, the other method was the extrinsic sympathetic control of the GFR. And basically here, we can kind of change the GFR on purpose, even when the arterial BP is in the range 80 to 100 millimeters of mercury. We do this through extrinsic control that override the auto regulation mechanisms that are in place. So intrinsic control of the GFR, it's controlled or mediated by the sympathetic nervous system, and they input to the afferent arterioles. Basically, we're trying to affect the long-term regulation of arterial blood pressure. So the example they talked about here is if we get injured and we're bleeding and we have a decreased level of plasma volume. In this case, our immediate thing is to get that blood pressure back up, and to do that, we're going to increase our cardiac output, and we're going to decrease or increase our peripheral, can't think of the word, peripheral resistance. Sorry. This is all coordinated by the cardiovascular control center in the brainstem, and we're going to kind of increase sympathetic activity to the heart and blood vessels. Again, we want to increase cardiac output and the total peripheral resistance, and that's going to help us raise blood pressure back to normal in the short term. But in this case, we still need to replace the blood volume that we lost, so we're going to do a couple things to do that. The first thing we're going to do is reduce urine output. By conserving the fluid there, we can build up the plasma volume again. And then we also have our baroreceptors in this extrinsic control. The baroreceptors are located in the carotid artery and on the aortic arch. When they notice that there's things going out of place, they're going to respond to a fall in the blood pressure, and it's going to sympathetically induce the vasoconstriction that occurs in most arterioles throughout the body, which includes the afferent arterioles, and that's a compensatory mechanism as well. So that's also going to trigger them to constrict, which reduces the flow of blood into them and keeps the GFR where we need it to be. GFR can also be changed by changing the filtration coefficient. Now, originally, this filtration coefficient was thought to be a constant, but two factors contributing to the filtration coefficient are surface area and permeability, and we can change those. There are the cells that make them up do have some contractile activity within the glomerular membrane. The two we're looking at are the mesangial cells. That'll affect surface area, and the podocytes, if they are moved around, they can affect permeability. So with the mesangial cells, because the glomerulus is kind of in a tuft or a grouping of glomeruli, by constricting those, those cells contracting, they can block off certain glomeruli, which limits the surface area and reduces our GFR rate. With the podocytes, they also contain contractile filament, and what they can do by contracting or something, they can open or close the slits that occur there, the filtration slits, and that will affect the permeability of what gets through and what doesn't. Okay, so our objectives here were to describe the composition of the glomerular membrane, to explain the forces behind glomerular filtration, to find glomerular filtration rate, and then discuss how that filtration rate is controlled in the body. And here are my references, and thank you for your time.